Yes, sir. I'll share the screen, sir.
Okay. Onkar should unmute. Yeah. Good morning.
Just asked him to
Good morning. So we to all the participants here. So we'll be having our academic session starting this month. But this month program is much less because of Puja leave. So the first to start with today is a case of left iliac fossa mass. Dr. Onkar Nath, who is a third year resident at MR Bangalore, will present, and Professor Ditendra Sarkar, Professor of Surgery at IPGM SSKM, will moderate the session today. So Onkar, you can share screen and start presenting.
So is the screen visible?
Yes, ask Onkar to start.
Yes.
শুভ বিজয়া মাখনদা।
শুভ বিজয়া ম্যাডাম।
কি হলো, অডিও ধরছে না?
So he's just joining again and starting, sir.
Okay.
Hello.
Yes, yes.
Sorry, sir. There was a network problem.
Okay. Onkar, you start.
Yes. Sir, Mr. X is a 60-year-old gentleman from Havra district, shopkeeper by profession, presented to the surgery OPD with the chief complaint of lump in left lower abdomen since 1 year, alteration of the bowel habit for last 6 months, rectal bleeding since 5 months, and pain abdomen since 4 months. History of presenting illness. Patient was apparently normal before 1 year, following which he noticed lump in the left lower abdomen, initially of approximately 5 into 5 centimeters, gradually increasing in size to attain current size of 9 into 8 centimeters. Patient complaining of alteration of the bowel habit for last 6 months. Previously, he used to pass stool daily, but for last 6 months, he is passing stool once in 2 to 3 days. There is also a history of bleeding per rectum since 5 months. Patient is passing stool. Patient is passing fresh blood mixed with stool 1 to 2 episodes per month, which persist for 2 to 3 days, sometimes associated with mucus with loose stool. He has also complained of intermittent dilating pain in his left lower abdomen since 4 months, which is gradual in onset, non-radiating, no aggravating factor, but decreased after defecation. There is history of anorexia and weight loss for last 5 months. There is no history of fever, vomiting. There is no history of any other swelling over the body. There is no any symptoms suggestive of distant metastasis. Past history. Patient is a known diabetic. There is no history of hypertension, tuberculosis, asthma, hypothyroidism, or any coronary artery disease. There is no history of any previous surgery and no history of any similar complaint in the past. Family history. There is no significant family history of any cancer in the first or second degree relative. Personal history. Patient is married, has a wife and 2 children, consume mixed diet, sleep is normal. There is no history of any addiction, but has altered bowel habits. Allergic history. There is no history of any allergy to food and drugs. Coming to the summary, a 60-year-old diabetic gentleman came with complaint of lower abdomen, lump in the lower abdomen, left lower abdomen since 1 year, initially of size approximately 5 into 5 centimeter, gradually increasing to current size of approximately 9 into 8 centimeter. Patient also complained of alteration of the bowel habit for last 6 months with increasing constipation, with frequency of passing stool once in 2 to 3 days, associated with bleeding PR since 5 months, fresh blood mixed with stool. There is 1 to 2 episodes of bleeding PR per month which persist for 2 to 3 days, sometimes associated with mucus with loose stool. Also associated with intermittent dilating pain in his left lower abdomen for last 4 months, which decreases after defecation. There is also a history of anorexia and weight loss for last 5 months. There is no any symptoms suggestive of distant metastasis. There is no any significant family history.
Okay. Sir, can we ask question to Omkar?
Yes,
at
yes.
this point? Yes. Now, Omkar, looking at the history that you have presented at this point of time, just based on the history, what do you think this can be?
Sir, this could be probably the colonic pathology, sir.
Colonic pathology. And do you think it's a benign or a malignant colonic pathology?
Sir, malignant colonic pathology.
Okay. Now, from the history only, what points suggest that this is a malignant colonic pathology?
Sir, first, from the history, sir, patient is a elderly male, which is a risk factor, with complaint of lump and bleeding per rectum, with increasing constipation, with a history of increasing constipation, and on examination, nothing. Yes, sir.
No. So,
and also history of weight loss.
Yeah. Anorexia. But how would you explain if you think that this is a colonic pathology and likely to be a malignant pathology from the history? Do you think the history that the patient has presented is in line with the normal classical sequence, or do you think it's abnormal in this particular patient?
Normally in the colonic pathology, there is a history of alteration of the bowel habit. There could be the history of bleeding per rectum, sir. And there could be the lump.
The only thing, Omkar, that does not suit here is that for a patient to have a palpable lump 1 year back without anorexia, asthenia, weight loss, without a change in bowel habit for 6 months, and then the symptoms begin is very unlikely. I mean, the sequence should be anorexia, asthenia, weight loss, then plus minus everything. I mean, the patient to have a lump in the left side of the abdomen, which you suspect as a colonic lesion, with that to a malignant colonic lesion, to does not have any other symptoms for 6 months is extremely, if at all, ever possible. Okay.
Yes.
So if the patient has palpated a lump 1 year back and found it to be 2 inches in size, and for next 6 months, the lump was only increasing without any change in bowel habit, without anorexia, asthenia, weight loss, without any bleeding PR, does not fit in. The second point, Omkar, is how do you explain recurrent passage of mucus and loose stools for a lump which is situated so high up?
Sir, there could be the sir. There is a history of increasing constipation on which there could be the action of bacteria which led to the mucus collection, and there is passage of the mucus.
So that's an alternate diarrhea and constipation which you are suggesting, isn't it?
Yes. Yes.
But classically, can this be a spurious diarrhea?
Yes. Yes, sir. It's spurious diarrhea.
Very unlikely for spurious diarrhea to occur in left high colonic lump lesion. It's more common in rectal carcinomas. Okay, and the reason why mucus is passed is because it recurrently stimulates the urge of defecation, and there is ineffectual defecation containing mucus and bit of stool material. But for a left colonic lump lesion to pass mucus is very unlikely down the line. Okay, so that does, if you have done it hypothetical presentation, Omkar, I would suggest that your sequence should have been different, because this cannot be a classical presentation that the patient has palpated a lump 1 year back without any other symptoms. Then the diagnosis cannot be unlikely to be a colonic lesion. If it is not a colonic lesion, if looking at these symptoms, what other things can give rise to such a presentation?
There could be tuberculosis. This could be due to tuberculosis.
Even if it is due to tuberculosis, the bowel, the lump present without any other symptoms present is very unlikely. There is a 6 months gap, look at it, Omkar, for the patient to begin with a palpable lump and without any other symptoms. The patient was progressing with only a lump for 6 long months. How can you explain these 6 long months of any colonic or general features of any other disease than except a growing lump? What condition can have this? From the history, any differential that comes to your mind, we will go into the clinical examination.
Other differential diagnosis could be diverticulosis.
Again, there will be symptoms of bowel symptoms. Without bowel symptoms, a progressive lump for 6 months.
Retroperitoneal sarcoma.
Exactly. So the next DD will be a retroperitoneal mass. You don't call it a sarcoma. A retroperitoneal mass which has been increasing in size, and in the last 6 months it had infiltrated into the colon, and therefore the colonic symptoms have started. That can be the only feasible explanation to this. Okay.
Yes.
And Omkar, you have given a hypothetical presentation. That is a problem. If you think of a mass in the right or left colon, or a carcinoma in the right and left colon, what do you think? Which side colon cancer has more presentation with lump?
Sir, lump is more common in right side.
Yes.
Right side.
So right-sided mass presentation is more. Left-sided, before the patient presents with a mass, he has other symptoms. And you are given the list of symptoms. A patient may not have all the symptoms. Try to understand. Most of the time, patient may have just a altered bowel habit. There may be no bleeding. So you have given all the classic features. That's true to substantial diagnosis. But you keep in mind that there is a sequence of events. So that sequence event is you should follow the usual presentation. Left colonic carcinoma present with mass, but it's not very common as it is on the right side. Okay. So try to understand that before the patient presents with such a large mass, patient has some feature, even some patient may present with obstruction. Some of these patients may present obstruction. There is such a large lump is there in the left side. So don't get biased with the diagnosis. You have to come to the patient scenario. So you are going back to the physical examination. So examination will not be virtual now. Physical, you have to see the patient present who is in front of you.
Yes.
I think we can pass on to the examination.
Omkar, you can continue.
Yes. Coming to the general survey, patient was examined in a well-lit room after taking proper consent with adequate exposure. Patient is alert, conscious, cooperative, and well-oriented to time, place, and person. Patient is well-nourished, average build, well-hydrated, lying in right lateral decubitus position. BMI is 22. ECOG performance score is 1. Pallor present. There is no cyanosis. There is no extra cyanosis, clubbing, lymphadenopathy, or pedal edema. There is no fullness in the supraclavicular fossa. Vitals. Pulse rate is 80 per minute, regular in radial artery. Blood pressure is 126/70 millimeter of mercury in right arm in supine position. Temperature is 98.2 degree Fahrenheit, and respiratory rate is 16 per minute. Coming to the abdominal examination, on inspection, abdomen is normal in shape. Umbilicus is central in position. There is visible fullness in the left lumbar region. All quadrants of abdomen is moving equally with respiration. On leg raising test, there is fullness becomes less prominent. There is no visible scar, sinuses, peristalsis. There is no renal angle fullness present. Hernial sides and the external genitalia is normal. On palpation, there is no local rise of temperature. Abdomen is soft, non-tender, no guarding or rigidity. A lump is palpable in the left lumbar region extending into the umbilicus and left iliac fossa of size 9 into 8 centimeter, which is firm, non-tender, globular in shape, regular in surface, has regular surface and well-defined margin. There is no mobility with respiration, but lump is slightly mobile from side to side and up and down. There is no evidence of any organomegaly. On percussion, there is no evidence of free fluid and no normal vowel sound heard on auscultation. On perrectal examination, anal tone is normal. Finger glove stained with blood mixed with stool. No growth palpable, no deposit palpable. On systemic examination is within normal limit. Coming to the summary, a 60-year-old diabetic gentleman came with complaint of left lower abdominal lump since 1 year, which increases gradually in size to attain current size of approximately 9 into 8 centimeters. Patient also complained of alteration of the bowel habit for last 6 months, increasing constipation with frequency of stool passage once in 2 to 3 days, associated with bleeding per rectum since 5 months. Face blood mixed with stool, 1 to 2 episodes per month, which persist for 2 to 3 days. Sometimes associated with mucus with loose stool. And it is also associated with dull aching pain in his left lower abdomen for last 4 months, which decreases after defecation. Associated with history of anorexia and weight loss for last 5 months, but there is no symptom suggestive of any metastasis and there is no any significant family history. On examination, patient is pallor and other general examination is within normal limits. On abdominal examination, an intra-abdominal lump was palpable in left lumbar region, extending into umbilicus and left iliac fossa of size 9 into 8 centimeter, firm, globular in shape, smooth surface, rounded margin, not moving with respiration but moving slightly up and down and from side to side. On rectal examination, finger glove stained with blood mixed with stool, no growth palpable. Other systemic examination is normal. Coming to the provisional diagnosis, a 60-year-old diabetic gentleman is a case of left colonic pathology, most probably of malignant origin, most probably carcinoma of descending colon.
Omkar, now looking at the findings that you have presented at this point of time, which area of the colon do you think that the lump is originating from, based on your clinical findings?
So it is a left-sided colon, most probably descending colon.
Descending colon. Now, what amount of mobility or you expect in a descending colonic lump? What type of mobility do you expect in a descending colonic lump?
Will it be freely mobile or will it be restricted?
Sir, it will be mobile, sir. It will be mobile.
What will be
Descending
the
colon mass?
mobility? What will be
Yes,
the
sir.
type of mobility? Side to side, above downwards, or both?
Sir, side to side.
In this particular patient, you told that there is also mobility above downwards. How do you explain a left colonic lump? Where exactly is this is situated? In the epigastrium or in the left lumbar region? Which area?
Sir, left lumbar region.
Left lumbar region only, 9 into 9
Sir,
centimeter.
extending into the left iliac fossa and umbilicus.
Left iliac fossa and the umbilicus. Okay, so how do you explain the above downwards mobility of a descending colonic lump? Because it is only the sigmoid colonic lump which can have an above downwards mobility. Descending colonic lumps are unlikely to have above downwards mobility. Why I am asking you is there is a reason behind this. So where do you think this is situated?
Most probably a descending colon.
Descending colon. Now, if you find a lump which is present in the descending colon, then how do you explain the above downwards mobility? That is what you told. Okay. Now, the second point is if you have a mass which is so high up, maybe just beneath the left splenic flexure, on digital rectal examination, finding the glove stained with blood is extremely unlikely, extremely unlikely. How do you explain that? Then there has to be a persistent daily bleed. Then only you can feel but your history tells once in a month there is history of passage of, I mean, you cannot tell blood directly. It's a stool which is stained.
It will make it.
So, you know, these are because you have created a hypothetical history. There are so many discrepancies. Because in a descending colonic lump, if you find frank bleeding in the stool, it has to be a massive bleeding.
Okay.
Or the stool color is altered. You cannot differentiate that this is blood and this is stool. This happens if it's a rectosigmoid mass or low sigmoid mass, or definitely a rectal mass. Get my point? So once presented this, it is obvious that you have actually done a hypothetical case. But if you do an hypothetical case, see, there are so many discrepancies which are cropping up as you are presenting. Okay. So, but if you tell it's a real life case, then we have to accept, then the questions comes differently. You have to answer the question why a left descending colonic mass has got an above downwards mobility. Then you have to tell that the mass is originating from the sigmoid colon. A sigmoid colonic mass can have an above downwards mobility and a side to side mobility. So you understand? Classically, a splenic flexure will have movement with respiration. Splenic flexure to sigmoid colon will have side to side mobility, no above downwards mobility. A sigmoid colon will have side to side as well as above downwards mobility. Beneath that, you won't be able to feel a lump. Clear?
Yes.
What would be the stool color in different phase, in different parts of colonic malignancies? Right side.
The right side there could be the black colored stool, sir, due to melena.
Classic black, like melena in the upper GI hemorrhage.
Sir, not classically black, sir, but it will be like there could be sir, blackening of the stool, sir, due to melena.
How, as sir has said, why the melena stool is black, typically black? It is indicative of upper GI hemorrhage.
Upper GI, yes.
In upper GI hemorrhage, it is black due to acid digestion. But as you go into the right colon, you will find dark colored stool. Don't take it as black. Black means upper GI.
It's ultra black.
Dark.
Okay. then deep
Yes,
down
sir.
or like that. And when will you start to find definite separate blood without stool in colon? That is usually rectal or rectosigmoid growth.
That's what.
When the patient can pass blood without passing stool. Above that, if you find that there is definite hematochezia, that is separate blood without stool, then it has to be a massive bleeding, or else you will find that because the colon will have adequate time to mix with the stool and the stool color will be altered, but separate blood will not be visible in the stool. You get my point, Omkar?
Yes, yes, sir.
Okay. So you, instead of telling left colonic pathology, you can tell it's a left colonic mass, which is probably a malignant colonic mass. Okay, what are the other differentials?
And there could be tuberculosis.
Okay, how would you differentiate between a tuberculosis and that of a colonic? I mean a malignant mass.
In tuberculosis, there will be there could be no history of passing mucus in the stool.
He may have.
And
It's a hyperplastic tuberculosis. It's a large mass. It's not a spongy type of tuberculosis. If at all tuberculosis, a hyperplastic tuberculosis. What other symptom patient might have?
yes, sir. Their patient could have cough, hemoptysis, dyspnea.
Hemoptysis?
No. Patient need not have a active tuberculosis in the lung in CA colon, tuberculosis of the colon. That is not mandatory.
The first thing, Omkar, you should tell left-sided tuberculosis. If it is a gut tuberculosis, it's mostly in the ileocecal region rather than in the left colon.
Left colon, yes.
So this is not the common position. If you do have, then you tell that the patient can have constitutional signs of tuberculosis, alternate diarrhea with constipation. Okay, what you were referring to at that time, it's not so common in malignancy, but more common in tuberculosis to have alternate diarrhea and constipation because of the stenosing or the hyperplastic lesion that you have. Okay.
Yes.
Any other differentials that you'd like to bring?
Retroperitoneal sarcoma.
Were you not referring to diverticulitis at one point of time?
Diverticulitis, yes.
Okay. So how do you differentiate between a diverticulitis, though it is not very common in our country, and a frank malignancy? Though, of course, diverticulosis can also have malignancy, but diverticulosis versus malignancy.
Well, sir, diverticulosis will have massive bleeding, sir.
Okay, that's it.
Why massive bleeding right at the beginning? First, a patient of diverticulosis will have constipation. That is a very common feature. You have constipation or silent features. Then if it leads to diverticulitis, then the patient will have a painful condition with or without passage of blood. And if there is peridiverticular disease, then the patient will also have features of sepsis. The patient will have a tender lump. So in this case, the lump is tender, nor there is rise in temperature, no features of localized sepsis. So diverticulitis is possibly not one of the provisional diagnoses. Okay.
Yes.
Any other differentials beyond colon that you can think of?
Retroperitoneal sarcoma.
Don't tell about sarcomas right at the beginning. You tell it can be a retroperitoneal mass. Okay?
Yes. Inflammatory bowel disease.
Inflammatory bowel disease. Now, if you tell it can be an inflammatory bowel disease, what would be the presentation?
Keep in mind the lump also, no? There is a lump palpable.
Yes.
So what?
See, Omkar, your stem is, as sir has told you, is a lump in the left lumbar region. The bowel change has come later on. But if you had presented to us with a change in bowel habit for last 9 months, with an appearance of lump for 6 months, then the clue or the stem would have been change in bowel habit. Now here it is primarily a lump in the left lumbar region. So keeping that in mind, what would be your differentials? Retroperitoneal lump you told.
Yes.
What are the points in favor and against retroperitoneal lump?
Sir, retroperitoneal lump will not be mobile, sir.
If you talk of the lump remains silent for 6 months, is it a point in favor of retroperitoneal mass?
Yes, sir.
The lump was just growing.
Yes, sir. It is in favor.
And point against is?
Sir, mobility, sir.
Yes.
The lump is mobile in this case,
Is it
sir. But
classical to have such? Is it classical to have such a bowel symptoms in retroperitoneal mass?
no, sir.
You see, large
There's no-
causing no bowel symptoms.
No alteration of bowel habit for such a long time.
Exactly. So that is what you should argue.
Yes.
Any other differentials you would like to bring, or you are happy with these?
No other differences.
Okay. Now theoretically, though practically I would not bring that into differentials. Now theoretically, another differential that comes for a silent progressive lump in the left lumbar region would be an unascended kidney.
Ectopic kidney. Yes, sir.
Yeah. Okay.
Ectopic kidney. Yes.
Here you can easily go above the level of the lump, so that, and there is a distinct gap between the costal arch and that of the upper level of the lump. So the question of this lump, a renal lump directly, is not visible, and that it is dull. But an unascended or an ectopic kidney can be one of the differentials. Okay.
Yes.
But don't tell in the exam at the first go. That you understand. You have all the bowel symptoms being there. So don't jump to kidney as a first go for DD.
Yes.
Sir, with your permission, I have to leave, sir.
Yes.
I beg your apologies.
Okay.
I take my apologies to Omkar as well.
Okay. Okay, good. Don't you proceed. I'll carry on. Omkar, with this provisional diagnosis, how are you going to proceed with this patient?
Sir, I will do investigation to confirm my diagnosis.
Yeah.
Investigation to stage the disease and proceed further for surgery.
Okay, fine. So these are three groups of investigation you will suggest. So how do you start?
Yes, sir. I will first proceed with the ultrasound of the abdomen, which is the extension of the clinical examination, to see the site of origin, any extension into the liver, any collection, lymph node status. It will tell about also the lymph node status. So, and then we'll go for sir.
So some more things. Ultrasound. Do you think ultrasound is here the lump is very large lump? It is easily palpable. How reliable is ultrasound to pick up bowel related mass? Is it a very good investigation or it is not very reliable?
Not a very good investigation.
You find it. But apart from that, this patient has got such a large lump, and Dr. Sarkar brought about retroperitoneal mass or kidney mass. So ultrasound is a very good investigation for two reasons. One is you assess the primary mass and you
Lymph node
assess the rest of the abdomen.
Yes.
Rest of the abdomen is what? Ascites. Ascites. Any lymphadenopathy? Liver. Okay. Any large omental nodules? Any large pelvic deposits? Small omental nodules cannot be picked up in ultrasonography. Okay. So ultrasound is important as an extension clinical examination, although it is not going to confirm your diagnosis of a carcinoma colon. It's just an extension clinical examination to give an idea. Okay,
Yes.
you have done ultrasonography and liver is free, there is no lymphadenopathy, no ascites, but there is a mass in the region, and ultrasound cannot tell you the mass is arising from the gut. Is difficult. What next?
Then I will go for colonoscopy and colonoscopy guided biopsy.
Okay. Colonoscopy and colonoscopy biopsy. Okay, fine. How you'll do a full length colonoscopy or just a colonoscopy up to the mass?
Yes, sir. Full length colonoscopy.
Why? Why do you need a full
Sir.
length colonoscopy in a patient who's got a carcinoma colon?
Sir, it will delineate the whole colon, and if there is any synchronous growth or polyp present, then it will
One
be
is synchronous growth. You have a left colonic mass, you might have another growth in the right side of the colon. So synchronous malignancy. What else is the colonoscopy can pick up?
stricture, ulceration.
One is the
Ulceration.
primary mass. Colonoscopy will see the primary mass, extension to the lumen, surface ulceration, and apart from this, you say the synchronous mass. Apart from this, what else?
Polyp, stricture,
Polyp, stricture. What else?
ulceration.
Where?
Ulceration in the anywhere in the colon, sir. Present.
What other pre-malignant conditions may be there in the colon, which can predispose to the malignancy? One you said is polyp.
Familiar. Yes, sir. Yes, sir.
One you said is polyp.
Sir, hereditary non-polyposis colon.
Yes,
Colon.
polyps you said. Yes, polyp. Apart from polyp, any other pre-malignant lesion which can be picked up by colonoscopy?
HNPCC.
HNPCC को क्या देखेगा तुम? HNPCC is there is no polyp. You find a growth, so it's not a pre-malignant lesion. You can find other evidence of ulcerative colitis.
Yes, sir.
Although this patient does not have a long history of ulcerative colitis, but the colonoscopy can pick up any evidence of ulcerative colitis, loss of vascular pattern, inflammation in the mucosa, pseudopolyp formation. Okay, so you take a colonoscopy biopsy. The biopsy report came back as a moderately differentiated adenocarcinoma. What is next? You got a diagnosis of moderately differentiated adenocarcinoma. What are you going to do now?
So then I will prepare the patient for surgery.
You told me three steps of investigation. Why do you jump to operation?
Investigation. Yes, investigation before basic baseline investigation for
baseline,
fitness.
you have not done. You have done only colonoscopy. Why do you jump to baseline?
Yes, sir. Yes, sir. 2 stages that is, sir. We will go for.
Why do you skip this step? This is very important. Staging the disease is important to plan management.
Yes, sir.
Because if you have a stage 4 disease, that management is different.
Yes.
So what inhibition do for staging the disease?
Sir, contrast enhance CT, sir. CT of the abdomen.
How is going to help in staging?
Sir, it will tell about the site, number of mass, synchronous growth.
You see, the staging is based on. I understand. Staging is based on TNM.
TNM. Yes.
So how CT is going to help you?
Sir, it will tell about this bowel layer.
Yes.
Condition of the bowel layer.
Yes.
Any extension into the surrounding structure, status of the lymph node.
Yes.
And status of the mesentery and peritoneum. Any collection in the abdomen.
You're not talking of liver. Liver is important.
Liver metastasis.
Liver, pelvis.
Any nodules.
Yes.
Present in the liver. Or
so try to understand. When you are saying an investigation for staging, you should understand what are the points you see in a standard CT scan. You look at the growth. to assess the T stage, you try to assess the pericolonic lymph nodes, whether this can be picked up in CT scan or not, and then look for any evidence of distant metastasis in the abdomen, liver, pelvis, any omental nodules. Any other investigation for staging? It's such a large mass.
For it,
Any other investigation for staging? How will you exclude chest metastasis?
sir, yes, sir. And CT thorax.
Yes.
We will go for CT thorax.
Yes. You should go for a CT thorax. CT
And,
thorax will exclude. Chest X-ray is not the investigation for excluding chest metastasis. Try to understand. Chest X-ray is not reliable for diagnosis of any pulmonary metastasis. For pulmonary metastasis, you have to do a CT of thorax. Okay. Okay.
Yes.
CT chest is done. CT thorax is done. No distant metastasis. Is a local disease involving the colonic wall. Minimal lymphadenopathy. What next? Any other investigation?
Sir, I will do LFT, sir, liver function test.
Yes.
Just to see the condition of the liver, whether liver metastasis. If it will be there, then LFT will be deranged, and then we will go for baseline investigation.
Do you think single metastasis in the liver will derange the liver function test?
Slightly, it will derange.
It may not be. Liver has tremendous reserve. Okay, so few metastases in the liver may not cause derangement of liver function, but you should do liver function test. There may be rise of serum enzymes. There may be rise of alkaline phosphatases. Okay, so you should do liver, but always the liver function test may not be altered. Okay. Anything else?
Yes, sir.
Like to have a CA estimation, CA?
Yes, the CA level. Yes.
Why? Why do you like to have a CA?
Sir, preoperatively, we check the CEA level. If it is more than 7.5, then it has poor prognosis. And then after also,
try to understand. CA level become elevated when there is invasive malignancy.
Yes.
And it get more elevated if there is a distant metastasis.
Distant metastasis.
Okay, so simple CA rise to 7 does not indicate poor prognosis. Is it doing a pre-op CA will help you to have a baseline value, and it will help you in assessing the progress of the disease, and at follow-up it will help you whether the disease is having a recurrence. Okay, so CA is not for prognostication at the beginning. Okay, what else?
Then I will do baseline investigation to for.
So what's your plan in this patient? What's your plan in this patient? What should be the optimal treatment planning for this patient?
Left radical hemicolectomy.
Your plan is to left radical hemicolectomy.
Yes.
Okay. How will you prepare this patient for surgery?
First, 24 hours before we will start the liquid diet. Stop solid diet.
So some more things has to be considered earlier to 24 hours. You already said.
So first we will do all the baseline investigation and go for
so you have done that. You already commented patient has got melena, patient is having bleeding. So it's not the 24 hours you correct any.
Yes, sir. I will. Yes. Sir, if patient has anemia, so we will go for blood transfusion, and we will check the nutritional status of the patient. And
albumin is low. Albumin is 2.2. How are you going to address the issue?
First, we will optimize the nutritional status of the patient.
How will you correct this albumin level?
This
patient has anorexia and weight loss. So keep in mind that lowering of albumin is indicative of a global malnutrition.
Malnutrition. Yes.
Okay, it's not
So-
that you just push a human albumin intravenously. That is not going to correct the nutrition abnormality. So try to build up the nutrition, because what is the problem with low albumin in a patient who is undergoing surgery?
It will lead to the increased risk of anastomotic leaks if there will be hypoalbuminemia.
One is anastomotic leak, and also your
Wound healing is delayed.
wound healing. So this will impair wound healing, and also may have higher incidence of anastomotic breakdown.
Leak.
So that has to be corrected before you go for surgery. So correct anemia, correct the nutritional status, and then
Dehydration, check for dehydration status of the patient.
yes.
Yes.
What else? Keep in mind that although there are some discussions that bowel preparation is not required, in our patient population who has got very high stool load, a bowel preparation is to be done. How do you prepare the bowel before going for chronic surgery? What are the ways to get a empty bowel?
Sir, 24 hours before the day of operation, we will start liquid diet, and on the evening before surgery, we will use Pegleg powder and to empty the bowel.
Pegleg is a brand name. What you are giving? What you are administering?
Sodium sulfate.
What
Sodium
else is there in this Pegleg powder pack? This pack is a brand name is Pegleg. What does it contain? What is the purgative here? The purgative is polyethylene glycol.
Polyethylene glycol. Yes.
And it also contains what? Have you seen the pack?
Sodium sulfate.
It contains balanced electrolyte solution.
Electrolyte solution. Yes.
Polyethylene glycol is a purgative. It causes severe purgation. It does contain some balanced electrolyte solution. So how do you administer this powder?
Sir, in 2 liters of water, we will add 1 sachet of Pegleg powder, and we will tell the patient to drink it in.
How this polyethylene glycol clears the bowel? What is the mechanism? What is the mechanism? This polyethylene glycol is a hyposmotic solution or hyperosmotic solution? No, this is a hyperosmotic solution. So once you give this polyethylene glycol, this imbibes water from the gut wall. Okay, this imbibes water from the gut wall, and that causes purgation. Okay, so that is the mechanism for using polyethylene glycol. Is a hyperosmotic solution, and it imbibes water from the gut mucosa and the wall. So that causes the purgation. So polyethylene glycol will cause a mechanical wash of the bowel.
Mechanical. Yes.
Fine. What else now? Correction of anemia, correction of nutritional status, correction of dehydration, then getting an empty bowel. What else need to think before surgery?
Antibiotic prophylaxis.
Yes. What antibiotic?
There
There is a regime for oral antibiotic, but most of the people now doesn't give oral antibiotic. You give a parenteral antibiotic. What time and what antibiotic?
Sir, 1 hour before the incision of 1 hour before the incision, and
1 hour or at induction of anesthesia. What drug you are going to give?
Sir, 3rd generation cephalosporin.
Only?
We will cover and one more anaerobic for anaerobic coverage, sir, metronidazole.
And also aminoglycosides. Okay. So you give the patient at induction of anesthesia or within 1 hour of surgery. This is what? This is a therapeutic antibiotic or is a prophylactic antibiotic?
Sir, prophylactic antibiotic.
Okay. What is the indication that you continue antibiotic for next 5 days?
Sir, if there is on intraoperatively, if there is, sir, evidence of perforation or obstruction.
Yes. So if you are
Or
giving this patient for prophylactic antibiotic, usually the regime is to continue for 24 hours. And if there is a contamination, continue for about 3 to 5 days.
Yes.
Okay, so patient is well prepared, and you said you will do a radical left hemicolectomy. What are the structures you're going to remove in radical left hemicolectomy with a growth in the descending colon? What is the operation you plan, and what structure you're going to remove?
Sir, distal 1/3 of transverse colon, descending colon, and at least 5 centimeters of the sigmoid colon.
5 centimeters sigmoid colon. What should be the minimum clearance from the tumor?
Sir, 5 to 7 centimeters.
Yes, it should be 5 centimeters on either side. But in colon, you're doing left hemicolectomy because if you tie the vessels, they need to resect a segment of the colon.
Yes,
okay.
And other structures are to be removed, sir. Will be the lymph nodes and mesocolon.
Mesocolon of
and
what?
the lymph nodes. Sir,
It's a mesocolic excision. Okay. And if you talk of lymph nodes, where does the lymph nodes lie in relation to the colon? Because to take the lymph nodes, you have to be very careful to tie the vessels at a particular site.
Sir, at the origin of superior mesenteric artery and inferior mesenteric artery.
Left colon is only inferior mesenteric. You see, left colonic lymphatics goes to the mainly the inferior mesenteric.
Inferior mesenteric, yes.
Okay. So
Yes.
as you take the colon, some lymph nodes come along the wall of the colon. What are those nodes?
Sir, pericolic.
Epicolic first. Epicolic. Then pericolic is
Pericolic.
along the distal branches. And where are the intermediate
And
nodes?
Intermediate.
Where are the intermediate nodes?
Sir, intermediate besides this are inferior mesenteric artery.
No. Intermediate nodes are along the branches. Inferior mesenteric is the trunk. Okay. Intermediate along the branches, sigmoid branches, left colic branch. Okay. So the nodes along the branches are the intermediate nodes, and the central node or principal nodes are along the inferior mesenteric origin, or if you take the transverse colon, it can go to the superior mesenteric. So you have to take this. What should be the optimal number of lymph nodes to be retrieved with the specimen?
At least 12 lymph nodes.
Yes, 12 lymph nodes should be removed for optimal staging. So once you have done this left hemicolectomy, how do you maintain continuity?
Yes, sir. I will go for sir, alveocolic, alveorectal anastomosis. Alveocolic
left hemicolectomy.
Alveocolic anastomosis.
You have done left hemicolectomy. How can you do alveocolic anastomosis? You are doing left radical hemicolectomy.
Colocolic anastomosis.
Yes. If you take it up to the mid sigmoid, it will be colocolic, transverse colon to sigmoid. Yes. Or if you're taking the whole of sigmoid, it should be colorectal anastomosis.
Colorectal anastomosis.
Confused. You have said you'll be doing a left hemicolectomy. So left hemicolectomy will remove this structure and you do a colocolic or colorectal anastomosis.
Yes.
Do you need to do a diversion?
Yes, sir. It will be helpful, sir, in the initial stage if we will go for diversion.
Diversion means what?
Sir, colostomy.
Colostomy.
Yes. Sir, transverse colostomy.
Have you seen a left hemicolectomy being done? And if you do a diversion, yes. now most of you are not doing a colostomy. First of all, you have to think if the patient is otherwise preserved. If the patient is otherwise preserved, anemia is corrected, hypertension is corrected, there is minimal contamination during surgery, a diversion is not mandatory. Try to understand.
Contaminant.
Diversion is more commonly done when you do a LAR or
Contaminant.
ultra low LAR. Okay. For a routine left hemicolectomy, a diversion is not mandatory or not being routinely done. This you do if the patient general condition is poor, if the patient has got anemia, patient has got hypoproteinemia, the other decision you do a diversion. Otherwise, diversion is not a routine for a left hemicolectomy. Okay, as you do in case of a low anterior section or ultra low LAR.
Yes.
You have sent the patient to pathologist. Okay, what are the things you expect from the pathologist to give you in the histopathology report, which will be important for planning your adjuvant treatment? Tell me.
So first will be it will tell about the histological grading, sir.
Yes, first is the
About
histological
type of
diagnosis. First is
Yes, sir,
histological diagnosis. Mostly it is adenocarcinoma. What next you like to know?
sir. Yes. Sir, yeah. MIC.
No. Go
MIS.
gradually. Don't pass on to the genetic analysis first. The most important is tumor type, is adenocarcinoma or not. Second is grading of the tumor.
Grading.
Third is pathology should give an exact idea regarding the depth of invasion into the wall. That means you get a pathological T staging. Okay.
Yes.
Then pathologist can give you an idea whether there is any vascular invasion or not.
Yes.
Okay.
Yes.
Then pathologist will dissect the lymph node for you. And if you go to the TNM staging, how does the lymph node staging occurs in TNM staging?
Yes.
Because it was not possible to have a lymphatic staging on a clinical examination or even on CT scan. Now pathologists give you a staging. How is nodal staging done in CA colon?
Yes, sir. First, NX, a tumor cannot be, and node cannot, lymph node cannot be assessed. And N0, no lymph node present. N1, 1 to 3 lymph node present. N1A, only one regional lymph node present. N1B, 2 to 3 lymph node present.
Yes.
N1C, if lymph node invading serosa or peripolyp fat.
More than 4 nodes.
Yes, sir. And 2 if more than 4 nodes, and 2A if 4 to 6 node, and 2B if more than 7 nodes.
And to C is, as you said, mesentery, serosa. Okay, so pathologist will give you now the nodal staging.
Yes.
And now, based on the pathology report, how do you decide about the adjuvant therapy in this patient?
If lymph node present, if lymph node is positive, then we will go for chemotherapy, adjuvant chemotherapy.
Lymph node positive, definitely. Second is, how do you decide about adjuvant therapy in carcinoma colon?
Yes, sir. Yes, sir.
Suppose I give not this patient. I give a situation. It's a stage 1 carcinoma colon. Stage 1 means
there is no
T1,
one,
T2,
there is
and
no
0.
need, there is no need
this
of
patient?
therapy.
Yes.
No,
So adjuvant therapy is not required.
Yes.
Stage 2 is a controversial group.
Controversial.
Stage 3 is mandatory. In stage 3, mandatory adjuvant treatment.
Yes.
What adjuvant therapy is usually prescribed for carcinoma colon?
Sir, Folfox regime and Folfiri regime. 5-fluorouracil, folinic acid, and oxaliplatin.
Yes.
As Folfox regime.
And Folfiris, you add irinotecan.
Irinotecan.
Okay.
Yes.
So now as you go into different regime of this adjuvant treatment, then there are different regimes. Some people continue for 12 cycles, some people 6 cycles. This regime varies in different regimes. Okay, so adjuvant treatment. Now, how do you follow this patient up in follow-up. This patient you have referred for chemotherapy. Patient has undergone full course of chemotherapy. And what is the follow-up protocol for patient having carcinoma colon?
Yes,
What is the follow-up protocol?
Yes, sir. We will follow up with CA estimation every 3 monthly for first 2 years, then 6 monthly for next 3 years.
No,
And
not CA. But first tell me the frequency of follow-up. At what interval you keep on doing the follow-up of these patients?
Sir, 3 monthly follow-up
For first 2 years.
for first 2 years, then 6 monthly for second, for after that, for
next 3
6
years,
monthly
6
for
monthly.
3 years.
And
Yes, sir.
then yearly.
Yearly.
What you assess in each follow-up visit? What you
Sir,
assess in each follow-up visit?
Yes, sir. Level of CA, sir, whether it is rising
Level of CA.
or it
First
is.
talk of clinical examination.
Yes,
For every follow-up, you do a clinical assessment.
Yes.
The first is clinical assessment. Take the good history. Any symptoms? Okay. So good clinical history. Do a clinical examination. And then do some relevant investigations.
Yes.
So initially, CA is a very good guide. If
Yes.
CA is showing rise, that indicates
Then it
that
is
there might be some
metastasis.
relapse or recurrence. So
Recurrence.
in that case, patient should undergo relevant investigation in the form of CT scan or colonoscopy.
Yes.
Okay. If in follow-up, patient has no evidence of this recurrence, at what interval you should do a colonoscopy?
Sir, if no evidence of
Yes.
metastasis, then 5 yearly we will go for colonoscopy.
5 yearly? No. Initially, it should be yearly.
Initially, it should be yearly. If
Yes.
no evidence of any
Yes.
recurrence, then we will go for 5 yearly.
Okay. I think we have gone beyond the time. Okay. So, Omkar, keep in mind that when you create a history, it should be because the real-time patient in front of you, you can't create new things. Okay.
Yes.
Any question from anybody? Anything in the chat box? No. Okay. Thank you, Omkar.
Thank you.
Thank you. Thank you.